I'm here to talk about, I'm a medical oncologist, so I predominantly treat people with high-risk melanoma or melanomas that are spread to other parts of the body. So when we talk about melanoma that's spread to other parts of the body, we talk about metastatic disease. And so where does melanoma usually like to go? Well, really, melanoma knows no boundaries, and it can go wherever it wanted to, and I think Dr. Shapiro put up that slide. But the most common places can be the lymph nodes, the lungs, the liver, and the brain and the bone. And unfortunately, melanoma has no blood test or markers that we can follow to see how patients are doing, or if a marker goes up, whether the melanoma has come back. Very different than something like prostate cancer. You know, men go and get a PSA done, and if their PSA goes up, well, they know they need to be tested for prostate cancer and checked for that. That's not the story in melanoma. But I'm here to talk about the very effective therapies that we now have. You know, when I first started here, and we've been doing these for an awful long time, I got up here being very hopeful that someday in the course of my lifetime, I would be able to talk to people about curing melanoma. Well, we're almost there, because we're actually curing about 50% of people now. And when I first started doing this, 17 years ago, we only cured 5%. And so we've made amazing strides in the last 5 years. And I'm just going to show you a couple of slides reflecting some of those treatments that have really changed what happens to people with melanoma. And so, again, this is just reiterating what I talked about. There's lots of new exciting therapies that are causing people to survive. And actually, we don't use the word cure in melanoma because we're so afraid to use cure in melanoma, because we never in our lifetimes ever have, quote, cured a melanoma patient who had melanoma go to other parts of the body. So we've gotten into the habit of talking to people saying that you're in remission for the rest of your life, or you have what's called a long-term durable response, meaning that the cancer is either stable or gone, and we don't have to treat you anymore. It just kind of stays there, and you have your normal life, and you don't have to worry about the melanoma. So before 2011, we had two treatments for melanoma. One was chemotherapy, one was high-dose interleukin-2. Neither one of those were great options. Interleukin-2 in about 5% of patients may have the ability, because it was an immunotherapy, to cause patients to go into long-term remission, but chemotherapy really never did. And the problem with high-dose interleukin-2 was that you had to have a stress test, you had to be in great physical shape. It had side effects where you had to actually put people in intensive care units to give them this treatment. And so it really wasn't a treatment that was adopted by a lot of facilities, and a lot of people didn't want to get it because they got so sick getting it. And many people would even die during trying to get it. So in 2011, after probably 10 years worth of research, we have been able to come up with new agents that have really changed what happens to our patients with melanoma. We have immunotherapy and we have targeted therapy. So we've been very happy to take that chemotherapy bucket and kind of put it in the back room and say, we don't need to use this anymore. So that's what I'm going to talk about very briefly, is a little bit about immunotherapy and a little bit about targeted therapies, because both of those treatments have really changed what happens. So as you can see here, targeted therapy is a way that we can actually shut down the signal that's causing the melanoma to grow. 50% of all patients who have skin melanoma or cutaneous melanoma, their tumors, when they spread, will develop a mutation called the B-RAF mutation. This is not a genetically transmittable mutation. It's a mutation that happens right within the tumor. So patients very commonly ask me, oh my goodness, I have a B-RAF mutation. Does that mean I need to have my family checked? And the answer is no. This is a mutation only within that tumor. Why is it important to know? It's important to know because we've been able to develop medicines that will block this B-RAF mutation. And if you block the signal, the melanoma stops growing. It's actually very amazing, and we're going to talk about that. The other treatment that we're going to talk about is immunotherapy, where we can actually get someone's immune system, your own body, no chemicals. We're getting your own cells to recognize melanoma as being things that don't belong and going to attack it. And so it's a really science, it's almost like science fiction, and we're going to talk about how science fiction-y this gets, where we can actually teach your body to go out and get the cancer. So when we can do that, that's why so many people who get immunotherapy for melanoma go on to be those long-term durable responders or have that remission for the rest of their life. And I tell my patients, I will officially tell them that they're cured when I retire. So the targeted therapies, so the B-RAF is the most common mutation that occurs in skin melanomas, happens about 50% of the time. It very commonly happens in younger people and in nodular melanomas. They have a tendency to behave a little bit more aggressively. Again, we talked about the fact that this is not anything that's spread to your family. And when we give patients who have a B-RAF mutation a B-RAF medicine, it's almost instantaneous that those tumors shut down. Why? Because it's that mutation that keeps sending a genetic signal to the cell that says keep growing, keep growing, keep growing. Well, now you put a roadblock, what happens? Those tumors disappear. We have patients here that have been in this hospital where we found out they have melanoma and they're in the intensive care unit and the doctors call me, and it's always Friday at 5 o'clock that I get that phone call, that we have a patient, he's very sick, but they have a B-RAF mutation. So, you know, Friday afternoons is when I take out my red cape and I fly down to the ICU. And these are pills. And I hand these patients pills to take. And by Monday, they're on their way home. That's how fast these medicines work. It's absolutely fascinating. If anybody told me that this is how fast it would work, I would say there's absolutely positively no way, but it's true. This person I was talking about gave him his pills on Friday, and honest to goodness, went home on Monday. Whole new person. Very, very rapidly acting. So for patients who have very quick growing melanomas, if you know that they have a B-RAF mutation, it's an amazingly good medicine to have on hand. One of the downsides is that not all patients go on to have these long-term durable responses when they get targeted therapy. Many times, about 75% of the time, you'll get the disease under good control and you'll have to go to something else because those people will eventually develop resistance, and when you get resistance, your cancer starts growing again. So we're working on finding ways to make these responses more durable, like immunotherapy, and actually looking at shrinking down the disease and then switching people over to immunotherapy to give them that advantage of the long-term durable response. The other nice thing is that these drugs are phenomenally good at getting into the brain. And as you know, patients with melanoma, 50% of them can get tiny little tumors that grow in their brain. Well, we now have wonderfully effective medicines that can get up there and clean out the tumors that are up there as well. Sometimes we need to give patients some very focused radiation to get rid of some of the bigger tumors. But if we have patients that have lots of tiny little tumors, many times we don't need to do anything more than just give them these pills as well. So this is how it works. This is the melanoma pathway. And as you can see, we use two medicines. We use a B-RAF inhibitor and we use a MEK inhibitor, because if you inhibit the pathway in two ways, you can control the disease for a much longer time. And many of the patients who go on to have long-term control of their melanomas are on the two medicines. And this is what we call a waterfall plot that goes to show all of the lines. Underneath the lines are patients that have had responses to the treatment. All of the patients above the line are patients that have not responded. So you can see that 75% of patients who have a B-RAF mutation are going to have their disease get better when you give them this medicine. But of course, not everything is for free and everything has potential side effects. And so what are the side effects of these medicines? Well, you can get joint pain you can get muscle aches, you can get a rash, you can be exceedingly sensitive to the sun, where even if you wear sunscreen and protective clothing and wide-brimmed hats, you still may get very badly sunburned. Some of these medicines can give patients very high fevers and chills. We have to watch your liver function tests, and you can also get what's called hand-foot, whereas on the palms and soles of your hands get very calloused and sore. And many times patients don't like to tell me when they get hand-foot, but it's a dead giveaway when you go to your doctor's office in your slippers. And I will always ask to look at the bottom of somebody's feet when they come in slippers or flip-flops, especially in the middle of winter, and they're coming in flip-flops. And the other thing is that if you just give patients a B-RAF medicine and don't give it with its companion medicine, the MEK inhibitor, we've seen some new cancers develop, like squamous cell skin cancer and other new melanomas, but the standard of care for these medicines is to give both together, and so you don't see that happen. And this is a picture of the calluses that you can see on somebody's feet. It becomes very, very painful to walk. Patients will also, that's a squamous cell cancer. Dr. Hale showed you that, lots of nice pictures of that. But these drugs can also give you, they look like warty lesions, and they kind of grow on your nose and your face, and they can be not so much disfiguring, but it makes patients very self-conscious. And so we then refer those patients back to their dermatologist to have those things removed. They're not cancer, but they're not pretty looking either. So let's talk about immunotherapy next. We started out using one immunotherapy medicine, and now we have two immunotherapy medicines. So this slide is going to explain to you how they work. Who in this room has not seen Independence Day? Really? Okay, I owe you a copy of Independence Day. Okay, so Independence Day is where the aliens, they're coming down to take over the earth, and these big ships come and position themselves over these major cities. Well, the president gets his Air Force, and they try to get and blow up all the aliens, but the aliens have a force field around these big ships. So with that in your head, we're going to use that as the model when we think about how immunotherapy works. So the CTLA-4 medicines, or a medicine called ipilimumab, that is the president and the Air Force. They're getting all their T cells active, and they're flying, and they're out searching for their melanoma. But when they get to the melanoma, sometimes some of the planes get in, but sometimes the planes hit that force field and they can't get in, they can't kill the melanoma cell. So we now have these medicines called PD-1 inhibitors. Well, PD-1 inhibitors, are on this side here. Well, the PD-1 inhibitors come in and they put holes in that force field. Well, once you get a hole in the force field, now you can get all those flyers in to get their rockets in and blow up that alien. So the CTLA-4 activates all your T cells. The PD-1 brings down that force field and makes the melanoma cells much more vulnerable to the activated T cells. And when you use them together, holy cow, what a great response you get. The neat thing about these drugs is that you can use both separately. You can give patients ipilimumab, or the first part, the CTLA-4 antibody by itself, because there are some patients whose melanomas have very weak force fields. And you can give them ipilimumab, which is what we did, oh goodness, for almost 10 years before we had PD-1, and we were still curing patients. We cured about 20% of patients with ipilimumab. Well, when we had PD-1 inhibitors, if we just give patients a PD-1 inhibitor, well, guess what? Now we can cure almost 40% of patients. And I said that cure word. Usually don't ever say that. But we also found that if you give ipilimumab and PD-1 inhibitors, a medicine called nivolumab, together, you get way more bang for your buck. The problem is, the more bang for your buck you get, the more potential side effects you get. And so when you give both of those medicines together, we can now get almost 65 to 70% of patients have long-term durable responses. So that's very, very exciting. And this is the curve that shows how patients who get the combination medicine do better than one medicine alone. And so what are the benefits? Well, the benefits are that has the potential to give you a home run. It has the potential to put your disease into long-term durable remission. And what's interesting about these medicines is that many times we never get rid of all the disease on a scan. Many times the disease will shrink up and then stop shrinking. And when you shrink up and you stop shrinking, it's what I call schmutz. And so you can live with schmutz as long as the schmutz doesn't grow. And if you see somebody that has the same thing on their scan for almost a year, guess what? It's time to stop. Because those people, that schmutz is probably nothing more than scar tissue. And we follow those patients, and those patients go on to live long, productive lives, never having their melanomas come back. And so that's very exciting. There are certainly some people where you give them this medicine and everything goes away. Well, then you know that you've given somebody a long-term remission. But they are interesting drugs because you don't have to have the perfect, pristine, nice little scan that's got nothing on it. You can have stuff and still go on and live a normal life. In fact, there's a patient of mine who went on one of the very first studies here at NYU with the CTLA-4 medicine back in 2001. Okay, it's what, 2016 now? So 15 years later, he still has the same gunk or schmutz in his lungs and in his bone as he did in 2001, and he's still here in 2016. Not on any medicine. Comes to see me now twice a year. He's good. These are amazing medicines. And so what are the possible side effects? So because we don't give you chemotherapy type of side effects, there's always the potential for other side effects. The most common are rash and or itching. I say and or because you can have an itchy rash, you can have a rash with no itching, or trust me, you can get itching with no rash, and that's what makes people crazy. Is because when you don't have a rash and you wake up scratching and itching, you think you're crazy. You don't want to call your doctor and say, hey, I'm all itchy, because you're afraid that I'm going to say, well, do you have a rash? And you're going to say no. But these drugs are notorious for causing diffuse itching without having any rash, or you can have them together. The other big side effect of these medicines is diarrhea. And we're not talking just a little bit of bad poopies. We're talking 15 to 20 bowel movements an hour. So it can be life-threatening if it's not treated appropriately. And so that's why we always tell patients, if you start having even one episode of diarrhea, we need to know about it. Because it can go from 1 to 20 in no time flat. We absolutely know how to manage it, but we can't manage it if you don't tell us. And so reporting symptoms is the most important things when it comes to these medicines. We can also cause endocrine things, which means we can shut off somebody's thyroid gland. Well, if we shut off your thyroid gland, what happens? When your thyroid regulates your metabolism, people will come in and say, hey, doc, you know, I'm really not eating, but I've gained 20 pounds in the last 3 months. Why? Because we've shut down your thyroid. So we have to replace your thyroid with a thyroid medicine, and that's usually something that's lifelong. We can do the same thing with people's adrenal glands. We can shut down their adrenal glands, which makes you feel really crummy. And so we have to give you adrenal hormone replacement or corticosteroids for replacement. We can also cause inflammation of the liver as well as inflammation of the lungs. Again, we know how to manage all of these. It's just important that patients report this to us so we can fix it. And what we tell everyone is that just because you have a side effect, it does not mean that the medicine is working or the medicine is not working. It's very important to manage side effects. We also know that by managing the side effects, the medicines that we give to manage the side effects have absolutely no impact on the treatment response. So if I give you medicines to make your side effects get better, you're still going to have a good chance that the medicine's going to work. So for you to continue to get your medicine, I have to manage your side effects. Because if you come in covered with a big rash, guess what? I'm not treating you that day. It's not safe. We have to treat patients when it's safe. And so in conclusion, I hope I've convinced you that metastatic melanoma is no longer a death sentence, that more than 50% of patients with metastatic disease now survive their illness. It is a very exciting time. We no longer have to give people chemotherapy. B-RAF mutations are great ways to shut off tumors that are growing very quickly, and immunotherapy is designed to try to harness someone's immune system so that we could provide you with long-term durable responses. But on that said, we're at 50%, which is way better than I thought I'd ever be. But until we hit 100%, we have to continue doing the research that we're doing. And to acknowledge, I really want to thank all the thousands of patients here at NYU who have participated in our research studies. And it's because of them that we have been able to advance this field to where it is now. And patients who still come in to participate in research will allow us to move that 50% to 100%, I'm sure, in the next 5 years. So thank you. We don't have to go through the questions again.